Hey guys, welcome back. After much technical difficulty, we're going to go ahead and record a lecture for the thoracic cavity part 3, where we'll talk about the mediastinum, the heart, and the pericardium. We'll probably get through about half of this lecture in this video, and then I'll have to make a part 2 video for the rest. For those of you who are in my fall 2023 class, just this part 1 video is going to be on your upcoming exam. The second half of this PowerPoint will have to be pushed to the next exam. Okay, so in the last lecture, we talked about the pleural cavities. The pleural cavities are on the two sides of the thoracic cavity, and they include or house the lungs. The area in between the pleural cavities is referred to as the mediastinum. Media, like medial, right? The area in the middle of the thoracic cavity. In general, the mediastinum is a highly movable, mobile area because of the looseness of the connective tissue that fills it and kind of the softness or pliability of the organs that are contained in that space. There's a lot of structures that are passing through the mediastinum, a lot of the large, great vessels and nerves and lymphatic tissue. So it's not like it's filled with just one highly structural organ. This is important because this allows for changes in pressure that occur during respiration. This allows for the heart, which is in the bottom of the mediastinum, to have the space that it needs to contract, as well as for the pulsations, the expansion and contraction of the elastic arteries that are in the area. So it's just highly mobile. Here you see the borders of the mediastinum. The lateral borders are the mediastinal pleura, where we start the pleura around the lungs. Inferiorly, the border is the diaphragm. The top border is the superior thoracic aperture. Remember that like bony border around the top of the thoracic cage. Anteriorly, the mediastinum stops at the sternum and costal cartilages. And posteriorly, it ends at the front of the thoracic vertebra. First, the mediastinum gets split into two major regions, the superior mediastinum and the inferior mediastinum. The division between the two is at a point called the transverse thoracic plane. The transverse thoracic plane is like an invisible line that cuts through the sternal angle. So the sternal angle, remember, is this little point between the manubrium and the body of the sternum. If you just draw a line there, above that is the superior mediastinum, below that is the inferior mediastinum. The superior mediastinum has a lot kind of going on, a lot of stuff passes through it. It has the great vessels, so the superior vena cava and the brachiocephalic veins that merge into it. It has the arch of aorta as well as the major branches of the arch of aorta, which would be the brachiocephalic trunk, the left common carotid artery, and the left subclavian artery. Also, we see the thoracic duct, which is, remember, the large lymphatic duct that is collecting lymph from below the diaphragm and then above the diaphragm on the left-hand side. It's one of the largest lymphatic vessels. Also, the trachea passes through this area, and then right at the bottom of it is where the trachea splits into the two main bronchi. The esophagus passes through the superior mediastinum and then actually passes all the way down through the inferior mediastinum as well. The thymus sits in the anterior region of the superior mediastinum. Sometimes it dips down into the inferior part, but I'll talk about that later. We also see multiple nerves that are present passing through the superior mediastinum. For example, we see the vagus nerves, we see the phrenic nerves. We also see the left recurrent laryngeal nerve. The recurrent laryngeal nerves are actually branches off of the vagus nerve. Recurrent means that the nerve is going in the opposite direction. So what happens is like the vagus nerves are coming down, right? They come down the neck and then they pass down into the superior mediastinum. Off of those vagus nerves, there's a branch that curves around and then comes back up again. That's why it's called recurrent, because it starts to go back in the opposite direction. These nerves are going to the larynx, so they are laryngeal. In the superior mediastinum, we only see the left recurrent laryngeal nerve. There is a right recurrent laryngeal nerve, but you don't see it down in the mediastinum. The reason is that on the right side, the laryngeal nerve curves off of the vagus nerve and goes up higher. So on the left-hand side, it's dipping down low and coming up. On the right-hand side, it's all happening up in the neck. The vagus nerve comes down, and then the recurrent laryngeal nerve just loops under the subclavian and goes back up. So it never actually makes its way down to the mediastinum on the right-hand side. If we were looking at those nerves, like from the medial aspect to the lateral aspect, the nerves are laryngeal nerves, then vagus nerves, then phrenic nerves. So laryngeal, vagus, phrenic. The inferior mediastinum, right, from this transverse thoracic plane down, goes all the way down to the diaphragm, is divided into 3 regions. And those 3 regions they're all kind of like divided up by the pericardium and the heart. So here in the middle in blue, you see the pericardium, right, which surrounds the heart. In front of that is the anterior mediastinum. So that's this dark green area. Then you have the middle mediastinum where the heart is. And then behind it, you have the posterior mediastinum. Kind of look at how the posterior mediastinum goes back behind the heart, and then it kind of dips down lower as well. Because of the way that the diaphragm is curved, the posterior mediastinum does end up kind of dipping down, to have this inferior part of it as well. There are some structures that again pass through both the superior mediastinum and the inferior mediastinum. For example, the esophagus, right? The esophagus is going to go all the way through both of them and then puncture through the diaphragm before it goes into the stomach. So here you can see a lot of structures that go through the superior mediastinum. Just to kind of get our bearings, this is where the heart begins right here. So above that is the superior mediastinum, right? The superior mediastinum goes from the heart up to the superior thoracic aperture. So like the kind of bony ring that goes around the top of the thorax. When we look, you can see again the great vessels. So these are the brachiocephalic veins. They go into the superior vena cava. You can see the ascending aorta and then the aortic arch. The major branches from the aortic arch are the brachiocephalic trunk, and then the left common carotid artery, and then the left subclavian artery. You can also see the trachea coming down right here. You don't see the bifurcation, but at about this level right here, it would bifurcate into the 2 main bronchi. The 3 things that I have starred here are the 3 nerves, or 3 pairs of nerves. Again, from medial to lateral, they are the laryngeal nerves, vagus nerves, and then phrenic nerves. So laryngeal, vagus, phrenic. We talked about the phrenic nerves previously when we talked about the diaphragm. Remember, the phrenic nerves the phrenic nerve comes down and curves around the side of the pericardium. It wraps right around the side of the pericardium, the side of the heart, and then it goes down to the diaphragm. And remember that each phrenic nerve innervates each respective half of the diaphragm. If you look at this bottom picture here, this does a nice job at showing us the recurrent laryngeal nerves. Again, the recurrent laryngeal nerves are branches off of the vagus nerves. So you can see, remember the vagus nerves are cranial nerves, right? That's just cranial nerve 10. So it's coming from the brainstem and out through the skull and then passing down the neck. You can see the vagus nerves coming down either side of the neck. It's just lateral to the common carotid arteries. On the left-hand side here, the vagus nerve is going right past the aortic arch, and that's where the recurrent laryngeal nerve begins on the left-hand side. It loops around the aortic arch right here, and then comes back up the neck, right outside of the trachea, as it makes its way up to the larynx. On the right-hand side, though, the recurrent laryngeal nerve does not start so low. It starts a little higher up in the neck. So you can see the vagus nerve making its way down, and then right here at the level of the subclavian artery, that's where the right laryngeal nerve curves around and then makes its way back up the trachea towards the larynx. This is not quite so realistic, but this does do a good job at kind of showing us where all of the structures in the superior mediastinum are. Again, the thymus, notice right here, the thymus sits in front of all of this. So on the last picture that I showed you, it didn't show you the thymus, right? Because the thymus actually covers all of this up. So the thymus was removed so that we could see all of the structures behind it. But keep in mind, the thymus does sit in front of all of this. You can see the large vessels here. You can see the trachea. And again, right at the arch of aorta, the trachea splits into the two main bronchi. The thoracic duct is shown here. This green line is showing you the thoracic duct. The thoracic duct, actually comes up and then crosses over to the left side. And remember, it empties lymph into the left subclavian vein. You can also see the nerves here. This does a good job at showing you where the left recurrent laryngeal nerve is originating down here versus the right recurrent laryngeal nerve originating there. And then again, you can kind of see the progression of the nerves from laryngeal to vagus to phrenic. So that's the superior mediastinum. The inferior mediastinum is from that transverse thoracic plane down. So from the sternal angle down is the inferior mediastinum. Again, we divide that into three parts: anterior, middle, and posterior. The anterior inferior mediastinum goes from the back of the sternum and transverse thoracis all the way back to the pericardium. The transverse thoracis is the muscle that radiates out from the sternum. The anterior inferior mediastinum can have the very bottom parts of the thymus, but that's only in infants and children. Remember, I just told you guys that the thymus is up in the superior part. The thymus is located up here. However, remember, the thymus is one of those organs that's actually biggest in infants and kids. And then after puberty, it starts to atrophy. It starts to shrink, and it gets smaller and smaller and smaller. So in adults, it's only up in the superior portion. But in kids, because it's so large, it can actually protrude down in front of the heart a little bit. The anterior region of the inferior mediastinum has the sternopericardial ligaments. These are ligaments that stretch from the pericardium and forward to the sternum to help anchor the heart. There are branches of the internal thoracic vessels. Remember, the internal thoracic artery and the internal thoracic vein go down medially, like on either side of the sternum. There are also some various lymph nodes, some other small branches of vessels, and some fat. This is a relatively small area though, because the heart does sit pretty close to the sternum. There's not much space between the pericardium and the sternum. The middle part of this inferior mediastinum, the borders just follow the pericardial sac. So it includes the pericardial sac and then the heart that sits inside of that pericardial sac. The pericardial sac does also surround the roots of the great vessels. So like the pericardial sac goes around the heart itself and then up around the beginning of the ascending aorta, pulmonary trunk, and then like the beginning part of the superior vena cava. We also do see the arch of the azygous vein, which I'll show you guys the azygous veins in a moment, as well as there is just part of the main bronchi kind of passing through here as well. The posterior portion of the inferior mediastinum is the area that's located behind the heart and behind the diaphragm. This area is a little bit larger than the front area, so there is a lot of stuff kind of passing through here. This region is anterior to the T5 through T12 vertebra and posterior to the pericardium and the diaphragm. And then, of course, medial to the parietal pleura, right between the lungs. Both of these pictures are showing you this area that sits kind of like behind the heart. The bottom picture, so it would be like the area down here, right? Or the area that's down here, because above that is the superior mediastinum. The two pictures is just the bottom one showing you the arteries in the area. The top one are showing you the veins that are in that area. So things that pass through the back of the inferior mediastinum. The esophagus. Remember we said the esophagus passes through the superior and inferior mediastinum. It goes all the way through the whole thoracic cavity and then punctures the diaphragm. And that's this, let me change colors, sorry. This tube right here, this kind of pink color tube, that's showing you the esophagus. It's located pretty posteriorly in the mediastinum, so like right behind the trachea. If you notice the trachea right here, the esophagus goes right behind the trachea. We see the thoracic aorta. The aorta, remember, is split into parts. There's the ascending, the aortic arch, and then the descending aorta that goes down, and that can be divided into thoracic aorta, and then once you go past the diaphragm, the abdominal aorta. So here, this is showing you the thoracic aorta. We also see various veins present. We can see the azygous and hemiazygous veins. So if you look at this top picture, the azygous vein is this vein right here. It passes down the back, and it's passing down like the right side of the vertebrae, the right side of the vertebral column, all the way from like the lumbar region up to about like the T4 level. So again, passing all the way up the right side of the vertebral column is the azygous vein. The azygous vein collects blood from the intercostal veins on the right side. And then it flows all the way up and it curves into the back of the superior vena cava. So like right at about like this level right here, the azygous vein comes up and into the back of the superior vena cava. On the left-hand side is the hemiazygous vein. So coming up on this side of the back, up the vertebrae, is the hemiazygous vein. And that's collecting blood from the left intercostal veins. So like the intercostal veins come through and empty into the azygos and hemiazygos. There is something called an accessory hemiazygous vein, but that's up higher. That's actually up on the left side up here. The hemiazygous and the accessory hemiazygous kind of connect to each other, and then they empty into the azygos. And then again, all of that goes into the back of the superior vena cava. We do have the thoracic duct, which I'll show you the thoracic duct on the next picture. There's various nerves. Remember the sympathetic trunks going up either side of the vertebrae. There are various lymph nodes that are present, and then the splenic nerves as well. So here you can see the azygous vein, venous system. Just to kind of get your bearings, you're looking in, all the thoracic organs have been removed, and you're looking at the inside of the thoracic cage here. So like the ribs curving around from the thoracic vertebra. The vessels, right? This is the superior vena cava and the brachiocephalic veins flowing into it. This blue vessel coming up the right side of the vertebrae and then curving into the back of the superior vena cava, that's the azygous vein. Coming up on the left side right here is the hemiazygous vein, and you can see how that curves over into the azygos. The accessory hemiazygos is up here. Again, these azygous veins, they're coming up the back. They are accepting blood from all of these intercostal veins. Remember, in between each of the ribs, we have intercostal veins. And then under the 12th rib is the subcostal vein. This is showing you the mediastinum, the full mediastinum in a cadaver. So on the sides, you see the pleural cavities, right? The rib cage, has been cut and pulled back. Down here, this is showing us the diaphragm. So between the pleural cavities and above the diaphragm is our mediastinum. You can see the mediastinum, again, remember, gets divided at the transthoracic plane is about right here. Below that's the inferior mediastinum. Above that is the superior mediastinum. Down here you can see the heart. You can see the beginning of the great vessels, so the superior vena cava, the ascending aorta, and then the aortic arch. And then over here's the pulmonary trunk going into the right and left pulmonary arteries. This is showing us the trachea coming down. Remember, back behind the aortic arch is where that's going to split into the, or bifurcate into the two main bronchi. Here, this is just another picture that's showing us the posterior mediastinum. In the posterior mediastinum, you can see here's the esophagus. The esophagus is just kind of in front of the descending thoracic aorta. The thoracic duct, I actually don't see the thoracic duct represented on here, but the thoracic duct is going to end up curving around towards the left side of the esophagus. I will show you it on the next page. The azygous vein you can see coming up here on the right side of the vertebra. We don't see the hemiazygous, but remember that would be on the left side of the vertebra. The vagus nerves pass down through the neck, through the superior mediastinum, and then they also go through the inferior mediastinum as well. And then the right and left sympathetic trunks are going down either side of the spine as well. I'm not partial to this picture, you guys. I'm going to take this slide out, so don't worry about this picture. Um, Same thing here. Don't worry about this picture, guys. We've already looked at everything that this is showing you. There's nothing new here. So don't worry about that. Okay, moving on. The pericardium. So the pericardium refers to the layers, the membranous layers that surround and protect the heart. The pericardial sac refers to literally the sac, the strong sac-like membranes that create this barrier around the outside of the heart and the beginning of the great vessels. The pericardial sac sits posterior to the sternum and from about the level of the second to the fifth or sixth costal cartilages, and then in front of the T5 through T8 or 9 vertebra. More concerned with the fact that the pericardial sac and heart sit behind the sternum and the second through fifth or sixth costal cartilages. When we look at the pericardial sac and the pericardial layers that surround the heart, we can separate the pericardium into multiple layers of membranes. The fibrous pericardium is the strong, protein-rich, fibrous external layer. This fibrous pericardium goes around the heart, and then it goes up and follows the ascending aorta till about the level of the sternal angle. So that's superiorly, it goes up to the level of the sternal angle. Inferiorly, the fibrous pericardium is continuous with the central tendon of the diaphragm. So it's anchored at the bottom to the central tendon, which runs in between the two halves of the diaphragm. So, you have the heart itself, okay? And then surrounding the heart, you have this strong fibrous pericardium. Keep in mind that the fibrous pericardium is inelastic. It does not stretch, okay? That is very important when we talk about some pathologies later. It does not stretch. So there is a firm barrier around the outside of your heart. Now, the fibrous pericardium is fibrous, right? It's full of protein fibers, so it's a little rough. It's not slick and slippery. The heart itself is also kind of rough. It's muscle. Think about when you cut through steak, right? When you cut a steak, like the meat, the muscle is grainy. So here we have these two grainy structures. We don't want them rubbing against each other because that would generate friction, right? That would have wear and tear on the heart. So we coat both the fibrous pericardium and the heart itself with really slippery, slick layers. Those layers are the parietal pericardium and the visceral pericardium. So the parietal pericardium lines the inner surface of the fibrous pericardium. So lining the inside of this strong fibrous layer is the parietal pericardium. And then it's continuous, right? It curves around and forms the visceral pericardium on the surface of the heart. Okay, so the two layers are continuous with each other. The visceral means organ. So the visceral pericardium is the layer on the surface of the heart. Okay, and then the beginning of like the aorta and the vena cava. Again, the two layers are continuous with each other. The space between them is the pericardial cavity. That's the space that the heart has. The space between the two layers is filled with pericardial fluid, serous pericardial fluid. These two serous layers are slick and smooth, and they're always moist with the serous fluid, so they can slide and glide alongside each other without generating any friction whatsoever. This visceral pericardium, the really delicate layer on the surface of the heart, is also called the epicardium. Okay, those two names are synonymous with each other, which epi means upon, cardio means heart. So the epicardium is the layer upon the heart. So here you can see a few things. First off, in the first picture, you see the heart here, and then the great vessels coming up, like the ascending aorta, the superior vena cava, and then you see the pericardial sac has been kind of cut and pulled away. But you can see here this white sac that surrounds the heart. See how it ascends all the way up to the aortic arch. It encloses the heart, and then inferiorly, here's your diaphragm. You can see how it blends into the diaphragm. This top picture shows you the central tendon of the diaphragm. So you have like the muscle of the diaphragm on either side, and the central tendon of the diaphragm is in the middle. That's where the pericardium is continuous, connects to the diaphragm inferiorly. Again, kind of same thing down here. You see the diaphragm, and then you can see how the pericardium is continuous with that central tendon inferiorly. There are two sinuses in the pericardium. So two like open, like blunt, like chambers, two open chambers in the pericardium. The transverse pericardial sinus and the oblique pericardial sinus. This first one, the transverse pericardial sinus, is the more important one. The transverse pericardial sinus is an opening or a sinus behind the aorta into the pulmonary trunk and in front of the superior vena cava. So if you look at this picture up here, right, this top picture, remember, again, what we're talking about is there's this sac, right, that's surrounding the heart and the beginning of the great vessels. So the pericardium kind of surrounds like up to this layer. When you're looking at this pericardium, like from the outside, there's an opening in it, right? You can literally like insert your fingers through or into this opening in the pericardial sac, the sinus. And if you insert your fingers into that opening, you'll see that it's going right behind, just where this pointer finger is going up in the picture, right behind the aorta in the pulmonary trunk, and then your finger will slide in front of the superior vena cava. Think about what those vessels are doing. The superior vena cava is bringing blood into the heart. The other two vessels are bringing blood out of the heart, right? Like the right ventricle pumps blood out through the pulmonary trunk. The left ventricle pumps blood out through the aorta. So this transverse pericardial sinus allows you to separate the vessels that are leaving the heart from the vessels that are entering the heart. This allows us to clamp these two vessels that are leaving the heart so that we can then divert blood flow to a bypass machine when we're doing coronary bypass surgery. So again, like if we're doing surgery on the heart and we need to divert the blood flow, we have an external machine that's working for the heart. We can clamp at that point right there so that, again, we're diverting blood flow to the machine instead of to the heart. The oblique pericardial sinus is a blind recess, meaning it's like a cul-de-sac, right? It's a dead end that partially covers the vessels entering the heart posteriorly. So like the oblique pericardial sinus is back here. There's this little covering in the back of the heart. Blood supply to the pericardium comes from the pericardiophrenic artery. So the pericardiophrenic artery branches off of the internal thoracic artery. Remember, the internal thoracic artery is like running down on the lateral aspects of the the sternum. So the internal thoracic artery is coming down here. And then there's a branch called the pericardiocophrenic artery. The pericardiocophrenic artery comes in and it brings blood to the pericardium, and then also down to the diaphragm. The pericardiocophrenic artery, it runs right alongside the phrenic nerve. So in this top picture, this yellow structure that you're seeing, that's showing you the phrenic nerve that runs down the sides of the heart and then down to the diaphragm. So right alongside that phrenic nerve is the pericardiocophrenic artery. That gives blood to the outer, like the pericardial sac, so the fibrous pericardium and the parietal pericardium. The visceral pericardium is right on the surface of the heart. It's supplied by the same vessels that supply the actual heart muscle itself. So the coronary arteries, right? The left coronary artery and the right coronary artery branch off of the aorta. And then they have various branches that go to the heart itself, as well as the visceral pericardium. Venous blood flow, like draining the pericardium, just goes in the opposite direction. So we still have a the pericardiocophrenic vein draining the pericardium. The pericardiocophrenic veins, though, drain into the brachiocephalic veins. If you look at this top picture, the bottom picture here, this and this, these are the brachiocephalic veins. So pericardiocophrenic veins are coming up the sides of the pericardium and then into the brachiocephalic veins. There is innervation to the pericardium. We have sensation. We can feel pain from the pericardium, and there's also innervation going into the pericardium. So we have afferent and efferent fibers. The phrenic nerves, you guys know that the phrenic nerves innervate the diaphragm, right? They also have branches that go to the pericardium. The phrenic nerves originate at the C3 through C5 spinal nerves. And this is actually going to be important when we talk about referred pain that a patient can feel. But the C3 through C5 spinal nerves give us branches that turn into the phrenic nerves, and those phrenic nerves carry afferent sensory fibers from the pericardium. So if there's too much stretching of the pericardium, or too much pressure rather put on the pericardium, then we feel that as pain sensations that are carried up through the phrenic nerve. Now, because the C3 through C5 spinal nerves also carry pain sensations from the shoulder area, if a patient has, too much pressure in the pericardium, or there's something irritating the pericardium, the patient will feel referred pain in the C3 through C5 dermatome, which is on the ipsilateral shoulder. So that's the shoulder of the same side. Okay, so if it's the right side of the pericardium, then the person will actually feel pain in their right shoulder. Which there's nothing wrong with their right shoulder, but it hurts. That's what referred pain is. There's no injury in that area whatsoever. But because the same nerve is carrying fibers from both, your body's not able to tell which part is actually hurting. Your body thinks your shoulder is hurting. The vagus nerve also, or vagus nerves also innervate the pericardium, but we're not really sure what it does. And then the sympathetic trunks have efferent fibers going to the pericardium, and they have vasomotor function. So they control blood flow to the pericardium. They can cause, vasoconstriction of the vessels going to the pericardium. Okay, So we'll talk about a couple clinical things having to do with the pericardium. And the first is pericarditis. You guys know itis means inflammation. So pericarditis is inflammation of the pericardium. Again, there are sensations that are carried from the pericardium, so we do feel inflammation of the pericardium. Pericarditis is usually associated with chest pain. It can be associated with pain that's referred to the shoulder as well. The chest pain from pericarditis is usually worse when patients take a deep breath because that increases pressure on there. And it's also typically worse when laying down. Remember, the pericardium is attached to the sternum, right? There are ligaments that attach to the sternum. So when you lay down, that can result in pulling on, kind of suspension and pulling on the pericardium. So deep breathing and laying down typically worsens the pain of pericarditis. It typically feels better when patients are sitting up and leaning forward. That tends to take some of the pressure off of that pericardium. When somebody has pericarditis, this can be associated with friction between the layers of the pericardium, and this causes what we call a pericardial friction rub. And you can hear that when you auscultate the heart or listen to the heart. It's associated with, it sounds kind of like rustling silk, but that kind of rustling silk rubbing sound is a pericardial friction rub, which is a sign of pericarditis. And then again, if your patient, has chest pain that hurts worse when they lay down and breathe, it feels better when they sit and lean forward. These are all signs of pericarditis. And then again, also referred pain to the shoulder. Pericarditis, sometimes we don't know. It's often we don't know what caused it. It can be associated with various different types of infections. So viral infections, bacterial infections, sometimes autoimmune conditions. So patients with lupus, for example, are more likely to get pericarditis or chronic pericarditis if they have a chronic autoimmune disorder. Treatment for pericarditis kind of depends on what's causing it. When somebody has pericarditis, we can give them NSAIDs, non-steroidal anti-inflammatory drugs, to decrease the inflammation. Patients who have, long-lasting pericarditis can be treated with a drug called colchicine. If it's bacterial, we give antibiotics. If it's associated with, fluid buildup, if they have fluid buildup, we can give them something called diuretics, like furosemide, a loop diuretic, which causes fluid loss. So it just kind of depends on what's causing it. Like the way that we treat it depends on what's causing the pericarditis. Okay, a pericardial effusion. We look at this word effusion. We talked about pleural effusions in the last video. Effusion is like when there's fluid infiltrating an area. So a pericardial effusion is when fluid infiltrates and accumulates in the pericardial cavity. Now there should be some fluid there. There's serous fluid, which is just a lubricating fluid. But when you have fluid starting to accumulate in the area, that's a pericardial effusion. Now, this is problematic because remember we said that the fibrous pericardium, the strong border around the outside, does not stretch. It is not elastic. So when fluid starts to accumulate in that area, it can start to put pressure on the heart. It can compress the heart, and that's what this top picture is showing you. Fluid accumulating is not going to stretch out the pericardium. Instead, it's going to squish the heart. This compression of the heart can cause something called cardiac tamponade, and cardiac tamponade is an emergency. Again, because the fibrous pericardium is inelastic, this anything that rapidly accumulates in that cavity will create pressure on that heart, which again can severely limit pumping ability and can ultimately be lethal if it's not treated. Again, this decrease in pumping efficiency occurs anytime that there is a rapid decrease in cavity size. This rapid decrease in space that the heart has can be caused by a pericardial effusion. So again, just for whatever reason, we see that fluid is accumulating in that cavity, say due to infection, for example. That rapid accumulation of fluid compresses the heart. We can also have a rapid accumulation of fluid in the cavity, and that fluid is blood. Like we can have blood rapidly accumulate in the cavity. That happens if we have anything that damages the heart wall and allows blood to leak out of the cavities of the heart and into that pericardial cavity. So for example, a stab wound that pierces the heart can allow blood to leak out into the pericardium. A heart attack, if somebody has a very severe heart attack, that can lead to perforation of the heart wall, which allows blood to leak out into that pericardial cavity. In that case, we call it hemopericardium. Heme is blood, right? So hemopericardium is blood accumulating in the pericardial cavity. Again, compressing the heart can lead to cardiac tamponade, which is possibly fatal. Note, both of these situations are rapidly compressing the heart, right? Because again, the pericardium's not elastic, it doesn't stretch. Cardiomegaly is something that can cause slow changes to the size of the pericardial cavity. Cardiomegaly is like an overgrowth of the heart. So the heart slowly grows in size. Because the heart is slowly growing in size, the pericardial sac can usually compensate for those slow changes. So that cardiomegaly typically is not going to result in cardiac tamponade, because as the heart is slowly growing, the pericardial sac can also slowly grow. So the difference there is that that's a slow growth as opposed to like a pericardial effusion, which is going to rapidly decrease the size of the cavity space. Pericardiocentesis is when we do a procedure to remove fluid from the pericardial cavity. This is usually required for cardiac tamponade in order to relieve the pressure on the heart. Here in this picture, you can see one angle that we can insert the needle at in order to remove that fluid. This is through the left subcostal angle. So subcostal is like beneath the ribs. If you look here, you can see like the xiphoid process poking down, and then the costal cartilages going down from that. The left subcostal angle is the little, like the angle there between the xiphoid process and the costal cartilages on the left side. So the needle is inserted in that left subcostal angle, and so between the xiphoid process and the left costal margin, the margin of those costal cartilages. So that's where the needle point is going to be inserted. Now you want to aim your needle or angle your needle towards the middle of the clavicle, or up like towards the shoulder. So here at the top you can see the clavicle. So the middle of the clavicle is like about right here, right? So angling towards that point or towards the shoulder allows you to go up into that pericardial cavity. You can also go in through the 5th or 6th intercostal space in at the lateral border of the sternum, and that's what this is showing you right here. Sorry, I don't know what these students are doing. It sounds like they're like, I don't know, they're banging on something very hard back there. Sorry for the noise, you guys. So if you're not able to drain the fluid well enough with a needle, surgery might be necessary. With surgery, what you can do is open up what we call a pericardial window, an opening in the pericardium in order to drain that fluid and then close up again. Okay, guys, I'm going to stop